This is a recording going through the cardiovascular risk factors and stratification material that's part of your AIA. So you should have downloaded your packet that comes along with this. And part of this is taking some time and just reading through your ACSM handbook, chapters 2 and chapter 3. So make sure you do that before you do that. Also be sure to read through the whole AIA packet prior to watching this video. It'll be good if you skim through it and review some of the information there before you listen to what I'm going to talk about. At the end of this recording, we'll talk about a case that you will do and answer on Blackboard. So let's review first cardiovascular disease. These are things that deal with the heart, coronary vessels, peripheral vessels, even the vessels in the brain. If you have cardiovascular disease, this increases your risk of a heart attack, sudden cardiac death, or even a stroke. Some of the factors that affect coronary or cardiovascular disease would be genetics, your biology, your behaviors, and your environment. Now, there are certain behaviors that relate to really good cardiovascular health. Some of these, not smoking, being physically active, a healthy weight, a healthy diet. These are things that are behaviors. We make an active decision whether to do these things or not. And then you also have ideal health factors, things like your glucose level, like your cholesterol level, even your blood pressure. These are things that are the result of a healthy lifestyle, but can also be the result of good genetics and good biology, those things. So let's talk about what a risk factor is. A risk factor is a condition, behavior, attribute that might contribute to the pathogenesis of the disease. It should be pointed out that some are modifiable and some are not. Some of these things are behaviors, and some of these things are our biology, our age, our certain medical status that impact our risk or our decrease of risk or increase of risk of developing a disease. You can have a risk factor, but it doesn't necessarily mean that it will cause the disease to take place. The best example is that person who is very healthy, doesn't smoke, exercises, and then has a heart attack. And the other example on the other extreme would be that person who smokes, doesn't exercise, is obese, eats anything he or she wants, and lives to be 100 years old. So it definitely is not a cause and effect, but it does increase your risk or maybe decrease your risk, depending what kind of risk factor we're talking about. Now, there are positive risk factors and negative risk factors. A positive is not a good one. This actually increases your likelihood of developing the condition. So, for example, if you are obese, this increases your risk of cardiovascular disease. If you have high cholesterol, this increases your risk of cardiovascular disease. A negative risk factor is one that decreases the likelihood of developing the condition. And we'll talk about one of the few negative risk factors there are for cardiovascular disease. So now what we're going to do is we're going to take a few minutes and we're going to try a case. So make sure you've gone through and have looked at what the risk factors are and some of the criteria or defining characteristics for those risk factors. And we're going to run through a case and see if you can identify which risk factors are present and which one are not. So now we're going to try our case. So let's look in your packet. You'll see the case about Mr. Anderson. You see his age. First off, ask yourself, is age a risk factor, being 38? His height and his weight. If you did the calculations of that, you would see that his BMI is 32 or so. His blood pressure, you should look at that and see where he's at with that. Look at his cholesterol. Okay. What's his activity level like? Is he currently active? We find out he smokes recreationally, and as you remember from our smoking cessation unit, that even smoking recreationally, that has harm associated with it. You see his family history, and make sure you look up to see, does that qualify for family history? His father having a double bypass at the age of 62, and you see a little bit information about his his family, his activity level, and what he's doing. So you should better look at this, answer the questions. What risk factors does he have? What are the thresholds at which the identified areas become risk factors for cardiovascular disease? Which ones are modifiable? Of course, his age and his family history would not be modifiable, but his other things might. Barriers. So this ties in some things which come into previous lectures that we've had, when you think about his overall ecological model, are there family support systems? Are there not? Does his job allow it? Are there barriers that way? So think about that. And then also think about what kind of behavioral interventions you might use for this individual. Has he started some activity? Where is he at in the trans-theoretical model of change? Is he apathetic to change? Or does he seem like he's motivated to change? So these are all things you should be thinking about that go along with risk factors. We don't need to separate out material and think this is just a risk factor case. Also think about all these behavioral interventions out there. At this point, we've just covered the major cardiovascular risk factors. So these are the things we look at when we say these are things that clearly increase the risk of cardiovascular disease. Now, there are other cardiovascular risk factors that may not have as much evidence, but have some evidence behind them. And you can see some of those listed on your slide. And in your handout, you should read through some of those. You see there's some differences in men versus women. The one thing I always like to point out when we talk about gender issues is that heart disease kills more women than cancer does. There's a lot of people who are afraid of cancer, as they should be. It's something that kills millions of people and affects millions of people's lives each year. But heart disease is more likely to kill you than anything else. Okay. Other things that we've talked about in class already is alcohol, for example. There might be some risk reduction for moderate consumption of alcohol, and that's 1 drink for a female and 1 to 2 for a male. But we also have to consider the calories that come along with alcohol consumption and the other behaviors that come along with alcohol consumption. Do you consume more calories when you drink alcohol? All those things that go along with that. You do have some data on race and ethnicity, how that might factor into some cardiovascular disease issues, so read through that. And then sexual orientation also factors into some behaviors, some feelings of discrimination, and ties into health behaviors too, so read through that. Metabolic syndrome is something else you should look at in your handout. This is someone who is on that verge of a heart condition or a stroke. They haven't had it happen, but there's a lot of things going on that increase their risk. So you see 3 out of the 5 of the defined risk factors. And if we look at that, all these things are kind of that preclinical level. You look at abdominal obesity, a little bit higher weight there. BMI is not on here though. Triglycerides are a little bit high. Cholesterols, the good cholesterols are low. The blood pressures levels in the 2017 guidelines for hypertension, these would actually be hypertensive numbers, but when metabolic syndrome was defined, these would be pre-hypertensive. And the fasting glucose isn't quite diabetes at that 100 level, but very, very close to having a diagnosis of diabetes. So these are patients who are right on that verge of having a disease state, or a combination of these things really increases their risk for cardiovascular disease. So now we're going to shift gears. We're going to talk about the steps you're going to take if someone comes to you and you're trying to determine, are they safe to begin exercising? Now this ties into risk factors, because risk factors, we're thinking about what's their chances of having a cardiovascular event. From the pre-participation screening side, we're trying to determine how safe are they to exercise so they don't have a cardiovascular event during exercise. We'll talk a little bit more in detail in a few minutes about this, but there's a shift that took place with the ACSM. It used to be that we would consider those cardiovascular risk factors as part of our screening process. Now, however, those risk factors are not considered in determining risk with exercise and the need for medical clearance. So those of you who've had this maybe in undergraduate or through certification courses, this is going to be a little bit different due to the new guidelines from the American College of Sports Medicine. Move on to the exercise pre-preparation health screening. Think about how this fits into our reasoning model. A patient comes to see us, we collect some initial data on them. During this initial data collection, this is when we're asking a lot of the questions that are addressed in this pre-participation screening. We're asking about activity levels, we're asking about their goals, we're asking about past medical history, and we're asking about any signs and symptoms that might be present at rest or during exercise. So when we think about a reasoning model, we are really talking about this area right now. So what's the risk associated with exercise? Why do we care? Well, there's musculoskeletal injuries, and we can think about injuries such as pulling a muscle. We can think about someone who gets injured playing basketball, jumping down, landing bad on the knee, someone who's playing in contact sports. That can definitely increase the risk of musculoskeletal injuries. And in your handout, you see some of the risk factors that really do increase someone's risk for musculoskeletal injuries. What we're really concerned about in this lecture, and ultimately when we think about patient safety, is that worst case scenario. Who's going to have the MI, the myocardial infarction? Who's going to go into a cardiac arrhythmia, which is very serious? And worst case, who would be at higher risk for sudden cardiac death? And what can we do to screen these people ahead of time to determine who's at the most risk and then make some recommendations based on that risk? One thing that you'll find, or you should have found when you read chapter 3 of your ACSM handbook, was that the risks associated with exercise are very minimal, especially when someone's doing light to moderate activity. It is very, very rare to have someone have a cardiac event if they're completing moderate to low or light to moderate intensity activity and they're in a stable medical state. Again, in your handout, you see some statistics on sudden cardiac death and cardiac events in adults. One thing to point out, when there is sudden cardiac death in young people, it tends to be a congenital hereditary abnormality. You see some of those listed in your handout. Unfortunately, sometimes it's associated with drug use or drug misuse, or even certain supplements, which make someone at higher risk, maybe due to some underlying disease factor, to have a cardiac event. In adults, again, you see most dangerous during more vigorous activity. And when you think about the heart contracting, what happens is the heart is pumping. And the theory is that maybe through the bending and flexing of the artery of the heart, there's some cracking of the plaques, and this results in platelet formation, thrombus formation, and then a blockage of a coronary vessel. So why are we doing this? Why are we screening? We want to really prevent that worst case scenario. We want to educate our patients about what could happen. We also want to stress that exercise is very, very safe. Other ways that we do this is monitoring vital signs during exercise. We need to monitor the patient, see how they're responding, and then, of course, be prepared for that worst case scenario. What would happen if someone started having chest pain, or they went unconscious, or they went into cardiac arrest? What would you do? So let's talk about the screening process that would take place. What you see in your handout is that the ACSM has updated this. As I mentioned earlier, cardiovascular risk factors are no longer part of the decision-making process. We no longer place somebody in a risk stratification of low, moderate, or high like we used to. And the terminology is just if someone needs further follow-up, it's medical clearance. The ACSM has decided to write guidelines that really leave it up to the provider to determine, can we see if the person's safe through just a subjective exam, a physical exam, or do they need a medically supervised exercise test? So the first step is what's recommended is just ask about current activity level. How active is the person? Are they participating in 30 minutes or more of physical activity on 3 days a week for at least the last 3 months? That determines if the person is active. And then you're looking for the major signs and symptoms of cardiovascular disease and pulmonary disease. These are things you should really memorize. These are things that are come up over and over again throughout our curriculum and also come up in your clinical practice. So you need to, as the healthcare provider, ask about these things, whether it's formally asking or through a questionnaire of some form, asking about these things. So chest pain. Okay, so looking at chest, neck, jaw pain, these are all things that make you think ischemia. Shortness of breath. We're not talking about shortness of breath during vigorous activity. We're talking about things such as just walking across the street, climbing one flight of stairs, mild exertion. Dizziness or syncope, losing consciousness. That can be signs of maybe a blood pressure issue. Orthopnea, that's when someone has trouble breathing when they're laying down flat. Or paroxysmal nocturnal dyspnea. This is the person who might have trouble breathing when they're sleeping. A couple hours into sleep, they wake up and they're really struggling to breathe. The idea is that people have heart disease or heart failure, I should say. When they lay down flat, there's a shift of fluid in their body, and these people have more fluid around their core, in their around their lungs, making it more difficult to breathe. Ankle edema, especially or particularly bilateral edema, this would be a sign of heart failure. Palpitations, so feeling like the heart is just racing or skipping beats. Intermittent claudication, this is calf pain during exercise, or a feeling of tightness or aching in the legs when someone's exercising, most likely due to inadequate blood supply. A heart murmur, where you actually hear the heart swishing or kind of a swishing noise as the blood goes through the valve. And then unusual fatigue with usual activities. Other things you should be asking about are known diseases. Are any of these diseases present? Again, these are things you might pick up on the screen. If the patient is going to do a self-assessment, or maybe you're working with a community provider and they want a way to screen somebody, the 2018 PAR-Q Plus is a great questionnaire. This has been updated a couple times since the last ACSM publication, and it's a little bit more specific to the things that would limit activity or require someone gets a medical examination. So you can see some of the questions in your handout. You have a copy of that. I would tell you, you don't obviously need to memorize that, but you should look through it and have a sense of the type of questions are being asked. And then after you see the algorithms, which I'm going to show you, it should make sense of why the questions are written the way they are. The other thing you should be asking about is how much activity is the person going to be doing. Are they going to just do a light walk, a light yoga class, or are they going to take up basketball? Now, the ACSM has put together two algorithms which are pretty helpful to look at. There's one for the person on the left side who does not participate in regular activity, and then on the right side for someone who does. And you see there's three different levels below each. The presence of diseases, no presence of diseases, and risk factors. Someone who has known diseases but is asymptomatic, that's a person who had a history of a heart attack maybe, but they're fine now. And the third is they have signs and symptoms of cardiovascular, metabolic, or renal diseases. So they report, yeah, I've been short of breath, or I have intermittent claudication. As you see, medical clearance is recommended for those with known cardiovascular disease or signs and symptoms. For those with no disease or no signs and symptoms, they can go ahead and start exercising. And you can see they can go into vigorous activity as they progress. The people who had medical clearance, they should, following medical clearance, probably do light to moderate, and they can progress as tolerated. Now we go over the people who have done exercise. The big difference with this one is if they have known cardiovascular disease and asymptomatic, and they've been participating, because you're in the algorithm on the right-hand side, they don't need medical clearance if they're doing moderate intensity activity. They do recommend medical clearance if they're going to begin vigorous activity, and then continue with moderate activity, and then they progress them as tolerated. And then for someone who has been exercising, but now they have signs and symptoms of cardiovascular, metabolic, or renal disease, the idea is they should stop exercising, they should go seek medical clearance, and then once clearance is given, get back into it. So these are the people, they've been exercising, maybe they've been fine, but now they're starting to have symptoms come up. A couple take-homes with this before you move on to your final assignment or your Blackboard submission are that, first off, exercise is really safe. Patients can exercise with very minimal exercise or medical supervision, medical clearance, especially if they're at that light to moderate intensity. Pretty much a safe intervention. The second take-home point with this is there are some patients who might need to go see their doctor, and it's up to the doctor to decide what type of level of activity or screening might be most appropriate to protect them. And the third take-home point with this is that as physical therapists, we can do a lot of the screening. We can ask the questions, we can screen somebody, we can work with somebody and determine, are they safe for exercise? Think about this from a kind of a wellness standpoint. You're going to see patients possibly who come to you just for general exercise and fitness, but then also think about those patients who you are going to see for rehab following a stroke, following a fall. Someone has multiple sclerosis, Parkinson's disease. A lot of these patients will have known cardiovascular disease, but what you're going to do is you're going to ask them, do you have chest pain with activity? Are you short of breath? Are you getting pain in your calves with walking? And you're going to screen those signs and symptoms. And most of the time you're going to find that, they're safe to exercise. They're not going to have those signs and symptoms present. You might collaborate with the doctor if you're concerned about it, but as a medical professional, you're going to make a decision that, given that they're here for rehab, I'm going to work with them. I'm going to keep monitoring them for signs and symptoms, but they're safe to go ahead and exercise definitely at that light to moderate zone. And then as they tolerate it, as they do better, we may make the decision to push them into the vigorous zone as we're monitoring vital signs, as we're monitoring their response to activity. So keep those things in mind. That's the big picture points with this. Now we're going to go on and talk a little bit about the case you're going to review and then answer the questions on Blackboard. Now we're at the end of our material, and this is the case that's written in the back of your packet. What you're going to do with this is go through this case, identify the cardiovascular risk factors that the patient has. On Blackboard, there's a checklist. You'll check all the ones that are present. Does she have signs and symptoms of any cardiovascular, pulmonary, metabolic disease? Does she have any metabolic diseases she reports? And then I want you to go to this risk calculator. You'll find the link on Blackboard. Go there, enter in her information into the demographics here. So go ahead and you'll see that at the website, her age, her gender, race, her lab values, and don't go off of what's in here. That's not the right answer right there. I was playing around with things and took a screenshot of that. Look at her 10-year risk and then her lifetime risk. And then go in and just change one risk factor. Change her to not smoking cessation. I want you to see how that changes her 10-year risk. And then based on everything would you give her medical clearance to start exercising? Or would you recommend medical clearance, meaning she has to go receive medical clearance first? And then would you let her do activities that are listed in the case or not? Okay. I mentioned earlier what this all means. Think about how you use this information in the health and wellness world, the general population, the inpatient, and athletic foundation. We'll talk later on in the semester about EKGs and about when we might use an EKG with an athlete or someone starting the activity, and when we may not do those things, or when that may not be recommended. Again, this all comes back to the reasoning model. We think about how we take this information, how we process it, and how we make decisions with it. Again, down at that initial data collection, we may get some information, and we may decide to do a systems review, and then some examination. And then we find something in the examination that makes us send it back to the doctor. Or we do the initial data collection and there's something obvious right away that has not been addressed, and we call the doctor, we consult the doctor, or we do our screen and everything's okay. We go around, we manage the patient, we get the patient better, and then we discharge the patient. But looking at risk factors, looking at that need for medical clearance and safety of exercise is the foundation of what we do prior to getting a patient up and moving them, prior to exerting the patient. So this brings to an end this topic. Again, make sure you get your Blackboard assignment submitted. Make sure you spend the time to go through the chapter, read the chapter. This short video is not meant to cover everything in detail. This was just a way to guide you through the material. So enjoy your time going through these topics. This is an important piece of information and one you'll use for many different times throughout your career as a physical therapist.